Hello, everybody. This is Dr. Walid Dabbas, a consultant and neurosurgeon from Al Balqa Applied University. I'm going to talk about the spine injury. By definition, is any injury to the bony elements, soft tissue, or the neurological structures within the spine is considered as a spine injury. When you have a patient with a spine injury, your concern is the first thing, is it the spine, is it stable or not? So your concern is the instability of the vertebral column, actual or potential neurological injury soon or later, if there is a potential chance for development of a chronic pain syndromes, further neurological deficit or decline in the future. It is the most common and frequent problem in young males. Again, the motor vehicle accident is the most common cause, followed by falls, sport-related acts of violence. Okay. Don't treat your patient as having a solo injury. When you have a patient falling down or RTA or a traffic accident or a sport injury, treat with your patient as a multi-trauma case. So dealing with him as he's having head injury, chest injury, abdominal injuries, long bone fracture, until proven otherwise. Okay, if it's usually associated with alcohols and drugs, alcoholic patients or patients taking drugs, more liable or susceptible for a trauma. 20% of patients with a major spine injury will have a second spine injury. So if you're having a patient in the ER as a victim of trauma, a quadriplegic from a cervical cord injury. So this doesn't mean you don't need to do a whole spine images to rule out other injury. You need to do it, because 1/5 of them, they have another spine injury. Pediatric population is completely different. They only 5% of spinal cord injury in children. C-spine is the most common segment. Okay, the fatality rate is higher in cases of pediatric with pediatric spine injury than with adult, which is completely opposite than the head injury. That the prognosis of pediatric head injuries is much better than the adult, while in the spine is worse. So neural and soft tissue involvements are common. What happens at the level of neurons is the trauma, spine trauma, will cause a local swelling at the site of injury, which lead to hypoperfusion and ischemia. This eventually will lead to release of neuroexcitatory material such as the glutamate, okay, with the area of injury will be infiltrated by immune cells, leading to free radical toxicity, and the end result is apoptosis and necrosis. The biomechanics of a spine, you need to understand the traumatic force and the mechanism of a trauma. For example, if there is an axial load toward the head, this will lead to the elements pushed together. Distraction, which means elements are pulled apart. Flexion is the severe forward bending of neck and head. Extension is a severe backward bending. Shear force is a parallel to the surface on which it acts. Rotational, which is a torsional forces. So in terms of classification of fracture, the fracture divided either is the spine is stable or unstable. Stable means he's able to carry normal loads. Unstable is unable to carry physical loads. Could be a simple fracture, could be a dislocation, could be a subluxation, could be a wedge or burst fracture. A column of Dennis or a 3-column of Dennis. We divided the vertebral body into 3 compartments. The anterior 2/3 of vertebral body with the anterior longitudinal ligament and the disc. This is an anterior column. Middle column is the posterior third of the vertebral body, and the PLL, the posterior longitudinal ligament, with the remaining posterior third of the disc. Posterior is the pedicle, lamina, facets, and ligaments. Any involvement of more than one column, we consider the spine fracture or the spine injury is unstable and need stabilization. The pattern of a neurological deficit, I mean the spinal cord injury, could the patient have one of the following syndrome? central cord syndrome, anterior spinal artery syndrome, which means an injury to the anterior spinal artery leading to infarction or ischemia of anterior two-thirds of the spine, Brown-Séquard syndrome, which is a hemisection of the cord. And actually, this is the best prognosis among these syndrome, and the worst is the anterior spinal artery. Here, a concept called a complete versus incomplete injury. What we mean by complete injury, that means the patient doesn't have any motor or sensory or sphincter function below the level of injury. So this is complete. But if he's having some sort of power or a sensation or tingling or sphincter control below the level of the spinal cord injury, if it is weak or residual, this means incomplete. And usually the complete spinal cord injury, this is an irreversible deficit. Irreversible deficit. While the incomplete, it might be reversible, or there will be some sort of improvement after you decompress and stabilize the spine. So this is an emergency. In cases of incomplete, you need to go to your patient immediately and to do the surgery, while the complete, you need to do it as soon as possible, but not in emergency pattern. Common conus medullaris syndrome, Coda-Equina syndrome. Okay. This is incomplete. I mean, a residual motor or sensory function زي ما حكينا. Look for sacral sparing sensation, voluntary anal contraction, toe flexion, bulbocavernous reflex. This means an incomplete, complete, no preservation of any motor or sensory function, and they usually have a periapism and abdominal breathing. Okay. Spinal shock is a transient physiological disruption which leads a hypotonic areflexic state. انتوا مثل ما بتعرفوا غير الاوتونوميك function is a function of the spine. So sympathetic dysfunction leading to flare up and activation of parasympathetic tract leading to a hypotonic and areflexic state. So the patient having areflexia and also having a hypotension and the bradycardia. Okay, and this should not impair the initial assessment. Sometimes your patient might give you a features of complete spinal cord injury due to spinal shock, but after 24 hours, he start to regain some of his neurological status. So usually in cases of high intracranial pressure, usually the patient presented with bradycardia and hypertension. But in cases of a neurogenic shock or spinal shock, they will have a bradycardia and hypotension, not hypertension. Okay, so you need to increase the blood pressure of the patient to keep good oxygenation and good blood volume supply to the spinal cord to prevent a secondary complication and the further damage to spine tissue. And you need to increase the blood pressure by giving the patient a dobutamine. Okay. Okay, usually the neurological status of the patient, 25% are normal, 20% they have a complete spinal cord injury, 55 incomplete lesion. We use the ASIA sheet to assess the neurological status for our patients. And this is the ASIA sheet. After that, you label your patient. If he's ASIA A, this means a complete spinal cord injury, so no motor or sensory function is preserved below the level of the lesion. ASIA B, that means a sensory but not motor function is preserved. ASIA C, non-useful motor function is preserved below the neurological level. D, useful motor function is preserved below the level of the deficit or the injury. ASIA E means abnormal. So treatment principle, any patient with a significant trauma, treat him as having a spinal cord injury until proven otherwise. So you need to stabilize your patient, to immobilize your patient, reduction of the fracture, neural decompression if there is a compression of the spinal cord, stabilize the spine, and rehabilitation and physiotherapy for your patient. So again, the initial assessment start with a brief history, check the vitals, check the Glasgow-Coma scale, ask your patient if he's having a back pain or neck pain, look for any spine tenderness, IV access, check the blood, give your patient the blood if he's hypovolemic, O2 mask, brief motor exam. Ask your patient to move arms, hands, legs, toes. Then stabilize your patient and then reassess your patient in a detailed manner. Okay? You need to put an NG tube for your patient, give him prophylactic PPI to prevent the stress ulcer, Follis catheter, bladder care, DVT prophylaxis. I give him a low molecular weight heparin or elastic stocking, or you might do an invasive procedure to put a IVC filter. Put a hard collar for your neck for your patient. There is no rule for soft neck collar in case of spinal cord injury. So you use a hard collar, Aspen collar, or Philadelphia neck collar. Okay. There is a rule for steroid for our patients in cases of spinal cord injury, not like the brain. So in cases, we can give him a methylprednisolone in a high doses in an infusion manner for 24 hours, and to trying to improve the neurological status for our patients. Okay, and to lowering the inflammatory response and the neuroexcitatory materials in the spine. So assess, immobilize, reassess, and treat your patient. Rehabilitation after stabilization of the spine in terms of mobilize your patient, bowel care, bladder care, pain management, pressure area care to prevent the pressure sore, psychological support, and placement. Imaging, we use the spine X-ray, AP and lateral view. In some cases, we need the dynamic X-rays. But if you have a CT scan, believe me, use a CT scan, because the gold standard test for diagnosing the bone pathology is to use the CT scan, not the X-ray. MRI, in cases if you have a positive CT findings, or the patient having a neurological deficit, or indicate a spinal cord injury, we need the MRI, and we need sometimes a biogram in cases of patients with CT post-myelo, in cases in patients that having a contraindication to do an MRI, such as having metals in his body, or having a pacemaker. This is a C-spine X-ray. You need to, if you want to give a report for this X-ray, you need to accept it. And if you accept it, you need to have a proper C-spine X-ray. I mean by proper, you need to see a 7 cervical vertebra. You need to see the junction above and the below. I mean the craniocervical and the cervicothoracic junction should be a true lateral, no shadow for other structures. Okay, you need to see the tips of the spinous processes. So if you see this, you can accept this X-ray for interpretations. So this is the C1, C2. This is the dens, the odontoid of the C2. This is the body of C2. C2 spinous process, usually the widest, while the tallest is the C6 and C7. Dorsal spine is not accurate. Lumbar spine, the accuracy is 70%. That's why we try to use the CT scan more than the X-ray. Now, I will divide the spinal cord injury according to the location into 3 categories. Atlanto-occipital dislocation, sub-atlanto-axial dislocation is the C1 fracture or injury, C2 injury, and subaxial. The atlanto-occipital dislocation is devastating. It is usually resulting in the cardiorespiratory arrest. This means, you can see here in the X-ray, it's a separation or dislocation between the skull and the cervical spine. It is account for 1% of spinal trauma. We don't know, is it 1%, or it is underestimated, because most of these patients, they die at the scene of the accident because of cardiorespiratory arrest due to spinal cord injury, due to brainstem injury, due to vertebral artery injury. So it occurs 3 times more common in children than in adults because of ligamental laxity. The mechanism of injury, it's hyperextension. It is unstable. If they reach the hospital, they need an immediate intervention and immediate surgery, a craniocervical fixation with screws. and rods. Spinal column atlantoaxial. Atlas is the C1, axial is the C2, so it is a C1, C2 dislocation. It's lower mortality than the atlanto-occipital. Usually, 1/3 of patients having a deficit. The main issue is the transverse ligament injury. This is the transverse ligament injury, which is the main ligament that is responsible for attachment of C1 to C2. Atlantoaxial dislocation occur more common in children than adult. Non-traumatic could be non-traumatic, such as in cases of rheumatoid arthritis and Down syndrome. And it is unstable, especially if the atlanto-dental intervallia. بنحكي عن هاي الدنس وهي الأطلس C1 arch. فإذا المسافة بين الأطلس والدنس 4 more than 4 millimeter or more than 5 millimeter, it is usually unstable and need a surgery as a fixation. C1 fracture, this is called Jefferson fracture. It is due to axial load. So leading to fracture of anterior and posterior arch. Usually it is stable fracture, unlikely to have a neurological deficit because of wide decompression of the spinal canal. And the treatment is with a hard neck collar, Philadelphia neck collar for 3 months, and re-evaluate your patient. But if he's having a ligamentous injury, especially a transverse ligament, it's unstable fracture and needs surgery. C2 fracture, we have the hangman fracture, is a bilateral fracture of the isthmus, of the pedicle of the C2. I mean the pars interarticularis, as you can see here. So this leading to subluxation between C2 and C3. فC2 بتسحل قدام C3. It is due to hyperextension with axial load. Usually it is a stable fracture. You might treat your patient conservative with a neck collar, but if he is having a ruptured disc and a subluxation more than 4 millimeter, this is unstable and need a surgery. Another example of C2 fracture is the odontoid fracture. It is a flexion injury. 15% constitute of all cervical injuries. Usually type 1 is the tip of the dens fracture. Type 2 at the junction between the dens and the body. Type 3 involving the vertebral body. Usually type 2 unstable. Type 1 and 3 are stable, can't be treated with a hard neck collar. Subaxial, I mean C3 to C7. The most common is the whiplash injury. It's a traumatic injury to the soft tissue, not to the vertebral body or the neurological structure. It is due to hyperflexion, hyperextension, no fracture, no dislocation. It is more common in automobile injury. Usually just they are presented with a severe chronic neck pain, and usual recovery, they need 3 to 6 months. Conservative management. Vertical compression, as you can see here in the C5, this is C1, 2, 3, 4. So this is a C5 vertebral fracture. It is a bursa fracture, more than one column involved. It is unstable. They require decompression for the cervical canal, cervical cord, and fixation. Compression with a flexion. Okay, this is a teardrop fracture. زي ما شايفين زي الدمعة. More common هذول بالدايفنج injuries. It is a posterior element involved in more than 50%. Okay, displacement of inferior margin of the vertebral body. It is unstable, require stabilization. This is a flexion distraction injury. It is a locked facet زي ما انتم شايفين. This is the inferior articular process came above the superior articular process of the vertebra above, but here is the vice versa. So this is a locked facet and with subluxation between the vertebral bodies. It is unstable fracture. They require reduction and stabilization. Involvement of posterior column, the lamina pedicle spinous process. Usually it is a stable fracture. No ligamentous injury is here, and the treatment is conservative. In cases of thoracic and lumbar, again, the 3 column of Dennis, if more than one column is involved, it's usually unstable fracture. These are modalities of fracture in thoracic and lumbar. This is a compression fracture, involvement of upper end plate. Okay, so it's compressed. The burst fracture, it is upper and lower involvement, which lead to kyphotic angulation. Chance fracture, it's the seat belt fracture. It's distraction starting from the posterior toward the anterior column. Flexion and distraction and translational injuries. These are unstable fracture usually, and they need a reduction and decompression and fixation. Usually, we use we immobilize our patient by using a hollow vest. As you can see here, this is more common used in the occipitocervical junction injury. Minerva jacket, again for occipitocervical junction. Hard neck collar such as the Aspen and the Philadelphia neck collar. The soft collar not used in cases of injury. Is there any hope for stem cell till now? Till now, no. Just for experimental and investigational. So it's not used for therapeutic for spinal cord injury. Thank you very much and good luck.